So just as a reminder, these sessions are recorded and they are viewed by the attendance administrator. So anytime that you're not in front of the camera, just make sure you put a message in the chat to myself. If you're having connectivity issues or any issue, just put a message in the chat, send it out to me. Don't send it to everyone. So let me pull up our course here. So we've already had one exam review. Let's pull up the schedule of the others. So at a minimum, make sure that you're committing to at least going back through the classroom recordings. Make sure that you are, looking at the exam reviews recordings. We know you all are in the last term here, so most of you all have several classes and clinicals and preceptors. But just commit to make sure that you're going back through our classroom recordings and also the exam review links. Let's see here. All right, I'm going to share my screen here. We have one on tomorrow. Make sure you put your name and campus in the chat. And remember that, it's timestamped when you log into the waiting room. So there's no problem. Okay, so we had one on Sunday. That link has been provided already. And then Dr. Tenza has one on tomorrow. That's 7 p.m. Eastern Standard Time. And then Professor Karen Foster has one on Thursday. So at a minimum, just commit to going back through the classroom recordings. If you can attend, make sure you attend the exam reviews. Dean Brown did send out an announcement for us to share with you all. So I'm going to pull that up as well. Be thinking about if you're going to need it proctored or not. Not sure what's going on. You may have, you might already be on campus. It's different scenarios. So be thinking about if you need it proctored. Remember that 72-hour notice that you got to give your campus dean, send an email to your campus dean, Dean Brown, and myself, so that the accommodations can be made, because we have to find a place and someone actually to proctor the exam. Okay, I'm going to pull up this message from her. Share my screen here. All right, so it says, this is from Dean Brown. Dear students, you have just completed your first exam. This is your first opportunity to review where you are and whether you need to, where you want to be. Now is the time to start thinking about, okay, what else can we do? Because remember last time I told you all, for the most part, we all did really well, but you want to do your very best. So think about those things that you think help you understand those concepts. And then also think about what else can you do? What else can you do to be successful? And not in just this class, but all of your classes. And then, so she wanted to outline various opportunities that you have available for you. So exam reviews, we do have them. Like I said, we have the days and times posted. At a minimum, commit to actually viewing them, because, it shows whether or not you actually view them. So make sure you go through that part. The attendance is always, has been low here lately. So she just want to make sure that you all do know that they're available, those exam reviews. Tutoring, if, and I put in my announcement, send days and times, but we know you're busy. You have different, you got work, school, you have clinicals, all these different things. So send an email with dates and times and we can coordinate something, or we can actually meet. Then, of course, always go back through your weekly content review, your required readings, and then the classroom recordings. Make sure that you're going back through those. Okay. She's just saying, wait until week 11 after the HESI exam is done. It's not the time to start thinking about what can be done. The time is now when things can be done to actually help you. Okay. Remember, you have to have that outright 78% without rounding. 77.8, 77.9 is not an outright 78%. Rounding upgrades it is only less than a full point away, as this violates the policy. So if it's 77.9, that's not an outright 78%. So that's what that means. Finding extra credit, all the assignments and everything is already built into the classes. So there's no such thing as extra credit. Everything is built in. She's saying retaking an exam for this policy does not allow retakes on exams to increase scores. As a reminder, if you have issues going on, it doesn't matter what the issue is. Please put it in writing. Send an email to myself, your campus dean, and Dean Brown. No issues too big or too small. Um, Make sure that you put it in writing. If you're sick, and go ahead and get your documentation. If you like, for example, if you have to go to the hospital, doctor's office, a flat tire, whatever it is, go ahead and gather that information and upload it and add it to that email, that communication. Before we can help you, after you submit your exam, you have been removed of everything out of our reach and are now asking to have policies violated for your benefit. So just make sure, even with the time you all are given that 75 minutes to take your exams, use that time. For the most part, most of you I do, but just want to just remind you of that. You have that 75 minutes to take that exam. And she's just saying, I hope each of you take this time to review your individualized situation. Think about what you have going on. You do not want to be in a situation where you're hoping to have a policy waived, because we just can't waive those policies because it means we'll violate them. So just think about whatever it is, those things, those tips and things that works for you. Find out what your learning style is, and then kind of, for example, if you like to hear things, you can actually record yourself and play back what you actually you're recording, and see if what you said was correct. Verify it, check it against the book, and then that for both ways. You're hearing it, you recorded it, you heard it, and then you validate. So just that repetition, you're going to automatically start remembering things. And then those concepts that you have a question about, go ahead and send an email or reach out about those concepts so we can go ahead and fine tune and get that good foundation. So no matter how that concept is presented to you, because it's next gen, you have to be able, for the most part, know the concept and be able to apply the concept. So it's rare that they ask you, what to describe an apple. It is, you have to know what an apple is and be able to put it together in a recipe and come up with the apple pie. So be able to apply it, so to speak. So that was the latest thing that she asked us to share today. All right, so let's go back into our course room here. Let's look and see. We're at week 5. Next week, we take the exam. So we will finish up all of our content today. So we just pull up the video, that week 5 points to ponder. It's just a little short video. Let's look at that real quick here. Let me share my screen here. It's just a little 6-minute video here. Let's see. Uh-oh.
Professor, I don't think no one can hear the video.
Oh, you all are not hearing it. No one can hear the video. Is that what you're saying? Let me stop sharing. No one can hear the video.
No.
Oh, okay. Not sure, but it's in the let me see. Let me try one more time. It's in the announcement. I'm not sure my volume is turned up. Must maybe one of those connectivity things, but let me just try it one more time. Let me go back to it. Okay, it's on mute. I've unmuted it. Are you all able to hear it now? Still can't hear it?
No,
Okay, so we'll just so make sure
it's
you view.
paused.
Yeah, I
Well, you gotta
paused
play
it.
the
Yeah, it's
video
paused.
first. Still no.
Okay, so yes, it's in the announcement section. So just make sure you take the time to actually look at it. I'm not sure connectivity can't figure it out sometimes, but it's just going in depth about the leadership and management. So remember, you're going to be those leaders at those, those in those different settings. So, it's not just you, it's all those team members. And it's not, for clinicals, you may have like one or two patients, but then remember how preceptor is, you have like that whole team. So if you're that leader, you got this whole team, it's more than just you and just your patient. So just keep that in mind. But then you still have the opportunity to advance within that organization. So just seek out those opportunities. Okay, so let's talk about delegation. So in the chat, before we pull up our PowerPoint, um, just go ahead and in the chat. What are those points, those things that you must do to correctly delegate? What are those things that you need to think about or ensure that are all met and to ensure that you properly delegate? So in the chat, just take it a moment to just put it in the chat. And you can just send it out to everyone. What are those 5 things that we must think about when we are trying to delegate, when we are delegating? Give you like a minute or so to put them in there. Delegation. So just think about who, what, and I'm just giving little hints, not trying to tell you what they are. I don't want to say that stable versus unstable, but it falls under one heading. The who, the what, and then are we really relieved of that duty? Just some things to think about. Let me look at the chat and see what you all are putting in there. Okay. Yeah, so there it was connectivity issues. Yes. Like I said initially, whenever you logged in, it's timestamped. So no, it won't count against you. So knowing your scope, competence, yes, knowing whether or not they're able to carry out the task. Like what is their scope of practice? What is their skill set? Correct task. Is this the correct task? Well, we asking an unlicensed personnel to administer medication, to draw up insulin. It's a circumstance. Is it stable or unstable? Is this patient? Because if the patient is unstable, but the task that needs to be completed is a task that the unlicensed personnel can complete, would we still delegate it to that unlicensed personnel if the patient is unstable? I see heads going left to right. So that is correct. It is no. So even if it's a task that they can't complete, the whole thing is that circumstance correct? And what we mean by circumstance is the person stable versus unstable. Okay. And so even though we delegate that task, the patient's stable, it's a task that they can complete. We've communicated what needs to be communicated correctly. We ensure that they understand the information and what's required to complete the task. Then are we relieved of that duty, of that task? Nope. We have to still make sure that that task has been carried through. Okay. I think we got them got all of them. Okay. So yeah. So remember those when it's asking you. Now, for the most part, I remember students are saying on the HESI, delegation scenarios are really, really huge. So that was with, 205. So I'm sure this still being leadership, I'm sure it probably is going to be similar. So just make sure that all of those components are met. And if one of them has not been met, then we can't delegate. Okay, so let's share a screen here. Okay, so we have the licensed practical nurse as that first line leader. So, we're that person that everybody's going to be coming to if we're that charge nurse. And even if we're not the charge nurse, if we have a team and you have unlicensed personnel working, if you have the other members of the team that's taking care of that patient's getting respiratory therapy, they're getting physical therapy, you're that nurse for that patient, they're going to be coming to you. We have to supervise nursing assistants, and we want to develop our leadership and management skills as well. For the most part, most facilities, they do offer those continuing education classes, and then also they'll have like little what they call lunch and learns, so that you can actually, actually real live practice those skills in scenarios. So mission statement and vision statement. Remember, this is the purpose. This is the why this organization exists. If I am going to ABC Hospital, what does ABC Hospital have to offer me? What is the purpose? Why are they there? If I'm going to ABC Urgent Care, what can I go there and just get my vaccinations done? Can I go there just to get this pain taken care of? What is the purpose and the goals of that organization? That's that mission statement. So we work toward that vision and we lead the team in fulfilling that committed mission. So if the facility is a skilled nursing facility and they say, hey, we provide skills needed for wound care, we provide diabetes management. So they're looking when they select that facility to come stay for whatever time, they're expecting us as the healthcare team to provide those services for them, which goes back to that mission. They mirror each other. They go hand in hand. So an expanded role, we want to review your state's current nurse practice act on the exact roles and boundaries. So, especially if anyways, no matter what state that you're licensed in, you still want to review your nurse state practice act. Even though that facilities, policies, and procedures should come from that nurse state practice act. Because they shouldn't be asking us to do anything that's not on our to-do list. And our to-do list is that nurse state practice act. So you still want to make sure that you review it. And if you are someone that's working in more than one state, a multi-state, remember, look and see what that state's nurse practice act says that you can and cannot do. And just keep that in mind as you go through and change up the different states that you're working in. So we do have the organizational charts. For the most part, you probably have in the different settings you've been doing clinical in. Some of you are working these settings, so you have pretty much seen all these different people, playing these different roles. And got the nurse right there in the middle. So everybody gonna be coming to you, for whatever pretty much is what's going on with that patient, to have your input or just to make you aware of, well, hey, this patient, we're doing physical therapy with them. The physical therapist will be here, Monday through Friday. And so at between the hours of 8 and 9. Why is that important? Because that patient may also have a doctor's appointment away from that facility. And who's making those appointments is usually the nurse, between the nurse and social services in some facilities. And so it's important to know that physical therapy, if this is the skill for that patient and this patient is not there, then they kind of get dinged on it. So they run the risk of their insurance company saying, hey, well, they're not there for that skill, but we want to pull physical therapy out from seeing this patient. So it's important to know. So they're going to come tell you, what updates, changes, and everything. And then we tell them also updates and changes with the patient as well. But there are so many others that we will run into as we're providing that care for that patient. But just know that more than likely you're that focal point. They're going to be coming to you. Anything that's going on with our clients or patients or residents, depending on what setting you're in, a disease process. I always go back to dietary. Are they getting the correct calories? Is the food items, are they appropriate for whatever disease process that we have going on with that patient? So dietary and the nursing, they work together pretty closely. So here's another organizational chart here. We do have, depends on how large that facility is. They may have two charge nurses on, depends on they're all different size facilities. There are hundreds, some facilities have hundreds of beds and some are small. They may just have that one unit or that two unit. And depends on that date, that time. So as you're going out and deciding the time of day that you want to work, usually as the day goes on, some facilities there's less. It's like the ratio is more. So you have one patient and then one nurse, and then you have more patients as the day goes along. So just keep that in mind. But again, it just depends on how that organization's chart is and how they have things laid out. So we do want to know the difference between the management and leadership. So the manager is just focused on the task. The leader also considers the people that are doing the task, how many people is needed. If we need to bring in another person from the healthcare team, that's what a leader's focus on. Managers mostly focus on, let's get this task done, and that's it. Okay. So leaders' motivation, they have that vision and strategy. Managers, they say power and control because specifically they're just trying to get this task complete. They're not thinking about, their goal or their focus is not all those other things. Okay. And so the leader includes listening and empowering. So you want to be that person where even if it's something bad, just let's talk about whatever it is and see if there's a solution. I can't find a solution. We'll figure out, who can. We'll ask someone else. Usually the spirit of inquiry, you all usually are, your new nurses, you have that new knowledge, you've been looking at the latest evidence. And so when you go into a facility, for the most part, you're like, I think we can do this task differently and save a little time, or we can do this task differently and save some resources. And so please share those ideas. A leader is going to welcome those ideas. And that's what's needed sometimes, because if we can save time and resources, so that lessens the amount that the patient will have to pay, that insurance company will have to pay for that patient receiving those services. Okay. And goal exploring and goal setting, again, because the manager's focus is on like completing this task, let's get it done. That's not a bad thing. It's just their focus is different. That's the only thing that this is trying to get you to see. So management, coordinate people and time and supplies to achieve the desired outcome. We focus on getting that goal completed. Have an appointed management position and a formal alignment of authority and accountability. So with this leadership, you may not have formal authority, but you're able to still influence others. You might be that go-to person where they'll come and say, hey, well, let me just bounce this idea off of you and just see, what you think about it. And, we want to welcome that, because you just never know. Someone to think of that one thing and it will say, we can revise that policy and procedure because we're still practicing within our scope of practice, but it can be done differently. And we can save time and resources. Because again, remember, it's not just you and one patient, it's you and that whole team of patients. And if you're that charge nurse, it's you, your patients, and you're overseeing the others that are there on that shift. So leadership, you have that ability to empower, influence the beliefs and opinions and behaviors of other persons. Again, coming to you with the good, the bad, and the ugly, being able to talk about it and seeking out resources. Okay. So how do we prepare for these management of this leadership role? Gaining, as we're life learners. No one knows everything, and we all going to always continue to learn as things are updated, as they get the newest evidence information, then things are updated. So, but nevertheless, we want to make sure that we have that good foundation with all the different concepts. You all are getting ready to prepare for those NCLEXs. So, once you finish your schooling, you want to go back through and make sure that you're going back through all those concepts. And then you're like, wait a minute, I've made it through school, but you still want to give yourself that chance to go back And just make sure, identify those concepts that you have, need a little bit more understanding of. And that's what you want to start with. Get it, making sure that you understand what is that process? How does this disease process affect the body? What organs are not doing what they're supposed to do? And as a result of that, okay, well, this is why we're getting these signs and symptoms. And then how do we help manage and take care of that patient? So basic nursing skills, including the nursing process, it goes back to assessing, gathering that data. We got to be able to manage our time wisely because we have that 8 hours or that 12-hour shifts. Now you hear about the 16-hour shifts, but you have that certain amount of time to get to take care of all of your patients and do all of those things, provide that care that they all need that's been identified on their care plan. So it's going to be really important that we manage our time. How to learn new information, including using evidence for learning and decision making. Like I said, most facilities, they always have something, some source of lunch and learns. They'll send things to your emails. They'll even have opportunities for you to go and get the new knowledge. Depends on what setting you're in. And then you come back and teach the group or do a video for the group with that new information. The power of positive self-talk and thinking. I know we pretty much, if you've been in nursing school, you know about that positive self-talk, talking yourself through, okay, I can make it, I can make it. But that's a real thing. We do have to encourage ourselves. Remember assertiveness. We're not being aggressive and we're not being passive. We're being honest, and letting our patients know whatever it is that they need to know. Having those communication skills, we talked about positive and negative. Those I statements are positive because you're putting it on you, and that helps to solidify and strengthen that therapeutic relationship that you're trying to establish with your patient. Remember those ethical aspects of healthcare. We're not going to violate HIPAA, ethical and legal. We're keeping things private. We are only looking at our patients' charts if we're involved in their care. We're not probing. We're not giving advice. Those are negative things. Problem solving and critical thinking. It's just an ongoing process, you all. Because remember, I don't think we rarely have a patient that just has one thing wrong with them, or one disease process that they're managing. And so it's just a fluid process. We're all the time, we're pivoting, problem solving, putting out fires, critically thinking, and this critical thinking part, if the situation is critical, that organizational chart that we showed you, if going up that chart does not give you those instant results that you will need, we're talking about an emergency situations and things are critical, then you bypass that hierarchy. But for the most part, if everything is stable, then you go up that organizational chart and you follow that chain of command. But if things are critical or emergent, you may have to bypass because you need an immediate answer or an immediate intervention. Stress management, on your days, if you're sick, they encourage you to call off. Make sure that you follow whatever appropriate, whatever the policies and procedures are about, if you needing a day for yourself, what they call those days, they have a name for them, but most facilities give you those days where you can, personal holiday, I think is what they call it. And so that you can, get yourself together, manage your time, take a little time for yourself and do some self-care. And then you will participate in evaluations. That's some facilities do them every 6 months, some do them every year, but nevertheless, you'll be given the opportunity to evaluate yourself to see and identify things that you need to improve upon. And we're all life learners. We all have strengths and weaknesses. So we all can stand for room for improvement. And then if we can do things with savings, a few steps, keeping the patient safe, we're not breaching confidentiality, we are not putting ourselves in harm's way. We want to reevaluate those things and revise those policies. So we do have a different leadership styles. And sometimes, it depends on what the situation is, you may use one over the other. But for laissez-faire, we're concerned with the employee. Now, there are some times that you don't want to just use certain leadership styles. For example, if there is an emergency that someone's pulled the fire alarm or they see smoke and, we have to go into the fire response. We don't want to just let people, well, hey, are we going to move the patients out of the place of danger? No, we need to be concerned with that task. You may have to, what they call it, I forget the response mode. We may have to, give those specific instructions. Hey, you go get the fire extinguisher. Let's move those patients out of zone A and put them in zone B. There are certain times when, you can use each of these leadership styles. If we're having each facility for the most part celebrates their staff. Sometimes they do it every month. Whoever has a birthday that month. So they may let the staff decide, well, hey, how do we want to celebrate staff that month? But if it's an emergency situation, and it didn't have to even be emergency. I know skilled nursing facilities, their residents have to be served a meal within every so many hours of each other. And so this is the example. So if staff just take breaks when they want to, then what if the staff takes a break during one of those times that patients have to be offered their meal? Well, and that those patients need assistance with their meals. Well, who's going to be there to assist them? So things like breaks, your lunchtime, those things are pretty much depends on the facility, because all facilities doesn't have that same structure. But if there's a structure where residents or the patients have to be served meals within certain times, that's why you'll see lunch times or break times scheduled at certain times within that shift, because they try to schedule them when patient care doesn't have to be actually given. And then usually there's a partner, or if I go on break, then I let you know, and then you cover. So they usually have that type structure as well. So democratic, there's that nice balance, and you consider everybody. What's the task? We're having to serve our patients meals. Who's going to serve them the meals? The employees. So what do we need to do so that these patients are served the meals in a timely manner? Well, that's why you have the certain times for breaks in lunch times. Okay, this is a little bit more detail. Laissez-faire gives away responsibility and authority to the employees, puts employees before the policies. You have a policy and procedure, but with laissez-faire, you kind of just don't pay them any attention. Tries to please everyone. Maybe nothing, but at least staff feels good. So never mind, our patients are not being taken care of, but hey, our nurses feel good about going to break when they get ready to. But remember, we're there to provide the best care for our patients. So laissez-faire would not be the best leadership style for that moment. When agency goals and policies are not taken into consideration, then we put ourselves at risk for legal and ethical issues, negative issues coming up. So autocratic, do not share responsibility and authority with employees. The emphasis is on the policy. Let's get this task done. What is it that we need to do to get it done? Tell employees what tasks to do. Does not seek input from the employees. And you may reach your goals. Crisis situations, like I was just saying about, we have not a fire drill, but we actually have a fire. So we got to go to that response. There's inclement weather. There's a tornado sighted in the area. So we have to go to those. What do we do in the event? So we can't be just, get the patients. No, we need to know what that policy and procedure says to do to keep us and the patients safe. And we need to follow through with that. What was the last storm that came up? And then that was an issue. It was like, it went back, and they captured on the news, and they went back to say, well, what was that policy? What was that facility's policy procedure for in response to, I think it was a hurricane or something, but they went back to, well, what were the employees supposed to do? Because they were like, well, why was so many patients still in the facility? I can't remember exactly where it was. But in the event that, so you want to make sure that you know what those facilities policies are. In the event that there's no running water, there's something happening, there's no running water. Do the facility have a generator? Is it one that automatically kicks in, or do we have to go out and push a button and crank something? We do want to know that. If there's no running water readily available, what is the facility's policy? Do they have water in one of their storage rooms? Is there have they have a contract that someone brings in water with to them. I know a lot of facilities, they do have contracts with their local grocery stores and that water, because you have to have that water available for those patients. So just make sure usually when you do the onboarding, they'll let you go over the facilities, policies, and procedures. Just make sure that you go through those, because we hope that we never have to go through emergency situations, but you just never know. So Democratic, we are sharing the responsibility. We're considering what the task is and also the employees and the patients. We're seeking input, from the employees, because we do want to, provide that best care. In the way we may have this policy might not be the better way to go right now. So, but again, want to make sure we're practicing within our nurse state practice act. So situational leadership. Situation is an answer. Depends on what's going on, what that situation is. It involves varying your leadership style to meet the demands of the situation in that work environment. According to this system, LPNs need to use a leadership style that fits the work situation at hand. The example that I gave earlier about, usually we follow the chain of command, but if it's something emergent, it's critical, we may have to bypass one person on that prong so that we can get that readily a solution really, really quick. It depends on what that situation is. So core knowledge and skills, of course, motivation, communication, the sender, receiver. Remember all those different techniques we want to use to make sure the information that was sent, that we receive, is actually correct. Validating, restating, paraphrasing, making sure what was actually communicated was really what was the message that was sent. Problem solving. It's just an ongoing thing. Team building and managing that stress. Take those personal holidays if you need to. So we know we use airway, breathing, and circulation to guide, whether or not things are critical. But then we want to go think about Maslow's hierarchy of needs as well, that physiological level. Food, water, shelter. If a person is in pain, if their nutrition isn't good, they're unable to eat, and they need someone to assist them with eating. We want to meet these physiological needs, and then we move up that triangle, the pyramid. Meeting needs on one level of the pyramid acts as a motivator for meeting the needs on the next level. And yes, we can go up and down the Maslow's hierarchy of needs, because, like I just said, if a storm comes, there's no water, our home is gone, or where we're living is no longer available, then we go back down to physiological needs. Our main thing is having somewhere safe to stay. So, but yes, meeting the needs on one level of the pyramid acts as a motivator for meeting the needs on the next level. When faced with overwhelming difficulties, physical or emotional, some regression takes place. For example, physiological needs become a priority. Think about a person that's lost their job or housing, like I just said, then you're going to be thinking you're going to go back to that physiological level. You're more focused on, where's my next meal coming from? Where am I going to stay? And if the place that I'm going to stay, is it going to be safe? How am I going to pay to stay there? So you can go up and down that pyramid, the hierarchy. Safety and security needs become a major issue if you are facing a serious illness. Is this neighborhood safe? Are you facing a divorce? Whatever that issue is, you had a flat tire, you just, your battery just went stopped working in your car, just whatever it is. But then if you're on the side of the highway, you're thinking about, are you safe or not? So it just depends on that, what's going on. Okay, so this one shows the LPN leader and nursing assistants. How do you motivate? This is Howlett's hierarchy of work motivators. What are the working conditions? Do we have, some facilities do like the self-schedule, or do you have to stick to whatever schedule, that rotation they put you on? Are you able to just work on Wednesdays and Thursdays if you like, or Saturdays and Sundays? What are those work conditions? And then, how much are they going to pay you? It, depends on those different settings. There are different salaries. So you want to consider all of these things, even with the safety in the workplace. Remember, I told you a lot of facilities, most of them, they don't want you to park up front. You have to, park wherever the employee parking is, and it's usually not near the facility. So you think about that. If they don't have security, and if you think that you're at risk for something, bad happening, is this a place that you want to actually work at? Those are things that you have to consider. What's going to be your responsibility here? If you're the charge nurse and then you're working on 11 to 7 and you have 300 patients in the facility and 150 of them are yours, is this something that you want to be responsible for? So you want to make sure that you're taking the time to ask those questions because things kind of differ on different shifts. But yeah, these are work motivators, things that we should be thinking about and asking in those when we go for those interviews and be looking at as you do your orientation and ask those questions. I noticed that, when I work on 11 and 3 to 11, there's only two of us here. Well, on day shift, I saw there were five nurses here. So you want to ask those questions because that's where you're going to be spending your time at. Is that a place that you want to actually work at? So motivation, drive that causes individuals to set personal goals and reach those goals. There are a lot of facilities that you can, they have certifications within that facility that you can be certified, and then sometimes they'll add to your salary. Now, keep in mind that you will be the person that they'll go to when they need that skill or task done because you're certified in that facility. But nevertheless, if that's a goal of yours, there's nothing wrong with that. So we have intrinsic factors and extrinsic factors. And so, what is it? Does this job, this facility allow me to reach or go up the ladder, or I'm just going to be doing this one task? If I work here 5 years or 10 years, is there growth? Is there room for growth and advancement? And there's no wrong to it. It's whatever your goals are. But we do need you to consider that. Okay. So job satisfaction, attributes, value, growth, real connection and empowerment. You go to work at a facility, does your leader or your manager, do they empower you and tell you, hey, we got this opportunity coming up. Are you interested in it? Or let's sit down and talk about it. Is this a place that empowers you to go up the ladder, to acquire those certifications that are out there? Are there any questions so far? So just like we have job satisfiers, we have job dissatisfiers. Those working conditions, like we just said, is it an unrealistic workload? I know a lot of places. Well, I've heard several people say, like when they go to those take certain assignments at a place that they don't normally work at. I forget what. Essentially, they're like travel nurses, but they call them something else. But anywho, a lot of times they're saying that the workload sometimes is unrealistic when you go into those facilities. And so you want to make sure, check it out. Well, what am I going to be expected to do? What's going to be my workload? And that's real. If you're having to make rounds on a patient at a minimum of every 2 hours and you have 15, 16 patients and you have to give, depends on what you're doing in that facility. Is it realistic? Is it safe for you to be in that facility? Can you really provide that best care for that patient? Things for you to think about that because you're going to spend just as much time on your job as you do, for the most part, in second place or maybe third place as you do home and with your loved ones. So you want to make sure it's a place that, that you feel comfortable, you feel safe, and that you like to be. Remember, communication is not just verbal, it's those nonverbal cues, those things in writing. We'll get a fax. Well, a lot of times, lab will call you on the phone, or if it's radiology, they'll call in the report, but then they'll also fax the report. So make sure that if it's deemed as critical, that we're following through, with that SBAR, communicating to that healthcare provider. Because more than likely, they're going to put your name down as, they've talked to you, report is being faxed. So just make sure that, we are following through no matter what the level or the kind of communication that it is. We go in to assess our clients and they're saying that they're not in pain. Also, look at those nonverbal cues. Are they frowning? Are they facial grimaces? Are they guarding? We want to note that as well. And then if they're saying that they're not in pain, but we see some nonverbal cues, we want to ask those more focused questions. I see that you're holding your stomach, or I see that you're frowning. Is it, you know, a reason that you're guarding your stomach? Does your stomach hurt? You want to ask those focused questions just to make sure that we're not missing anything. Team building, that most facilities are big on this team building now, because our jobs is taking care of people and providing that best care for them. It can be stressful. So they usually have team building exercises. They'll have times where you can, you all will go out and, on this, you all will have interactive activities that has nothing to do with patient care. You'll have an opportunity to play volleyball or be on that facility's baseball team or softball league. And so that they're saying that those team building exercises and opportunities helps us to be well-rounded healthcare professionals. So don't shy away from those opportunities if they have them. If that facility has, for the most part, they do though. They may have it where they have a cook-off, a chili cook-off or something. And everybody, they set aside a certain time of day. And if they don't have those things, maybe you start the conversation, because those things they do help with strengthening that team. Even if something bad comes up, that you can depend on the person on your team. You can go to them and talk to them about whatever is going on. Stress due to dysfunctional job behaviors. You want to make sure that you get enough rest. If you're sick and don't feel good, you're asked to, take that day off so that you can, feel better and you can come back and do your best. Create that less stressful work environment. If you know that you don't have the appropriate supplies, things, or whatever it is, your equipment that you're using needs to be repaired, follow those policy procedures and get those things reported, because that's going to add stress to you because you don't have what you need to take care of the patient. So ABC ways of increasing awareness or of irrational thinking. Activating, we want to believe, that self-talk about the situation. And then what are those consequences? And we want to dispute those irrational thoughts. But sometimes, your mind can be racing and it can take you the wrong way. So, encourage yourself, come back to reality, refocus, even when you're taking your exam, and looking at that clock is ticking down, still refocus, calm yourself, take the time to read through. You may want to speed up reading a little bit, but refocus, because sometimes your thoughts will run away from you. Again, another slide on creating that less stressful workful environment. It is real important because we are taking care of people. We're providing that best care you are, and that is a lot of stress. We're that center, as you saw that other slide. Everybody's coming to us. We're depending on us to have the answer, to know the answer for that patient, and also to provide best care for just that one patient. Nope, for all those patients. So healthcare providers, working environment can be stressful. So those things that we can do and identify, we need to identify them and have a discussion about. We do want to be respectful of everybody on the team. We can disagree, but we can still be respectful of each other. Are there any questions? I see we're at the bottom of our first hour. There are not any questions. We will pause and come back in 5. See you in 5. And you all remember this recording still plays. Just remember that it is still on. All right. So we have Nurse Bob. He asked Nurse Lisa. Nurse Bob and Nurse Lisa, they're talking. And Nurse Bob states, Lisa, why, he asks, why are they moving away from fee for service models? And they're replacing it with value-based care delivery models. So Nurse Bob and Nurse Lisa are talking. And he asked Nurse Lisa, I'm hearing this new trend now. They're moving away from fee for service models and they're changing it up to because they always have models and things that guides what we do. So that fee for service model is, if they go get their labs drawn, okay, you can get whatever, but there's a fee for it. So Nurse Bob says, I hear they're doing away with that and they're moving toward the value-based delivery models. What would be your response to Bob as to why do you think that they're moving toward that? They're moving toward value-based care delivery models. What is the whole purpose of that? So you can come off mute and you can just tell me what you think. They're moving away from fee-for-service models toward value-based care models. And then how do they measure that value-based care? What are they hoping to that patients will experience with that value-based delivery care? What do you think? You can come off mute and share. No guesses? Let me see. Am I
uh,
putting anything? Go ahead.
Focusing on the patient's outcomes, the quality.
Exactly. They're more focused on this. This is a person. This patient, they may have hypertension, they may have diabetes, but still we want them to be at that optimal level of care, that quality. So the aim now is improving that quality of care. Now they're still thinking about reducing costs now, but they're more focused on that quality. They're more putting it back on, this is a person that have needs, that have things that should be done if they have certain disease processes. So rather than just focusing on that service, okay, well, this person, we got to do a glucose check. We're going to, charge them for however they're going to get it checked every 4 hours. So we're going to focus on charging them for, 4 lances, 4 strips. And rather than that patient may need more than 4 glucose checks to improve their quality of care because in order for us to make sure that that client's glucose levels are stable. If that patient we go in the room and that person has altered mental status, they're cooling clamping, more than likely probably got to do a finger stick. Most facilities have those, standing orders where you can check their glucoses. But that fee for service is just focused on, well, we've already checked it the 4 times. And so we charge for that. So it is, she's correct. It's more focused on improving that quality of care, while decreasing those costs. So they're shifting toward that value-based care model. And, we're trying to see, well, is this important? These interventions, we can come up with all of these interventions, but are these interventions really important to this patient? So we want to include them in the care as well. And so how do they measure that? Have you all seen what they do in some facilities to measure or to determine what the quality of care that we're providing to our clients and our patients? What they do?
Looking at whether or not the patient has developed any facility type issues such as MRSA or bed sores.
Exactly. They look, even if we're putting in that Foley catheter, we usually send now, they want you to send that first specimen, to see, is that urine clear? Because you can put a Foley catheter in for a number of reasons. And if that patient gets urinary tract infection thereafter, it goes back to, well, okay, well, what was the technique? Was there a technique used? Was sterility broken? If a patient comes in or we'll say pneumonia, and they end up falling, they have some type of injury. Well, this patient came in from pneumonia. It's not expected that they would fall. So they go back and look at the data. And they even go around and ask the patients. It's actually a task of a nurse. They can go around. I forget what the title is, or it may be an additional task to that nurse. But I know in most hospitals, they just have like a person that actually goes around. They ask questions. Hey, did your nurse come in today? Did you see them wash their hands? They give them these questionnaires to answer. So yes, what they're doing is in some healthcare, some insurance companies, they're not paying for certain services provided. We're gonna take care of the patient, but they're saying because that facility, it was facility acquired, and that has nothing to do why that patient came in there. They're not wanting to pay all of those fees and charges that they're being charged. So what is that handoff report for? What is the handoff report? We are handing off to, we're going home. The next nurse is coming on. What's the purpose of that handoff report? So come off mute and share.
To make them aware of the client's status and condition.
Got it. Yes. So what their needs were, if they had they've just received medication, if they need to follow up, if a PRN was given, do we need to follow up? Are they on oxygen? Is there any follow-up care that's needed? Yes, that handoff report, and even if you are handing off from the patients being discharged from the hospital, going to home, back to their home, and they're going to receive home health, or if you're just changing shifts within the facility, that gives us that oncoming nurse that baseline information. It gives them information that they need to take care of that client. So can we give initial discharge instructions? As an LPN?
No.
No.
Okay, we can reinforce. We want to ensure that the information that we're reinforcing is clear. That the information, the instructions are clear. And then for the most part, they're going to always address safety for the clients as well. The safety is a big issue. That's part of when they bring the patient in, do you have stairs, do you have lighting and all of that. But just make sure that instructions are clear. If in whatever my first language is, those instructions need to be provided in whatever that first language is. But make sure that the instructions are clear and answer questions that they have. We may have to bring someone else in on the healthcare team to answer those questions, but we do want to make sure that they have enough information so that they can go on and provide that best care for themselves and be at that optimal level of care. Now, continuity of care. We kind of talked about that or hinted toward it when we were talking about the different people on the healthcare team. Continuity of care involves that transition from patient care between setting to setting within that same setting. For example, if the patient was in the ER and the person goes up to the med-surg unit, but it is that seamless transition, that handoff report, all the needed information is given to that next person. That ensures that patient's information and whatever that we need to do to treat that person it has been communicated, and so that we can maintain that coordination of care, that continuity of care. It lessens overlaps, it lessens gaps in care, but that continuity of care, they're big on that, and it goes back to that quality of care that we're more focused on now. And so that continuity of care, that whoever that you're exchanging that communication with, they need to know if there's any follow-up with any medications, any follow-up with temperatures that need to be rechecked, whatever that is, coordinate that care between the care providers, the nurse, the unlicensed personnel, the nurse to the patient, whoever it is. And so the whole goal is you are maintaining their optimal level of health so they can avoid complications. Because another thing that they base that quality on is what the person's being discharged to the hospital. They have to be blank. The hospital is pretty much kind of dinged on it. If they were being discharged to the hospital and that patient has to, I'm trying not to say the answer, but if they have to go back to the hospital, if they have rehospitalizations, that's another thing that they look at as well to measure that quality. They're saying that there must have been a break in that continuity of care. So that's like one of those buzzwords now. Continuity of care, rehospitalizations, where the patient must not have been well enough to go home. So that's why when you get ready to discharge a person, they have to, check the temperature. They have to look at certain things to ensure that they're really, in fact, ready to go. It decreases the likelihood of that patient being readmitted. Any questions so far? We've talked about the care coordination and those on the how we have to work with those on the healthcare team. Any questions about that? We're gonna get back to our PowerPoint. I'm just reviewing this. We talked about communication too last week. Assertive, we talked about aggressive. So give me your definition of assertive.
Being firm yet respectful.
Okay. Expressing ideas and opinions openly, while remaining respectful, giving them honest answers. And so give me an example of, so we have to know, remember, we got to be able to apply it. So give me a statement, example statement. You have a nurse and a patient talking, or, just a nurse and a nurse. Give me an example of a statement that's made that would be assertive. So we just said assertive was expressing ideas and opinions openly, respectful, and being honest. So let me give you some examples. You tell me if this is assertive or not. Well, Nurse George, this Nurse George and Nurse Lisa. I pick on Nurse George and Nurse Lisa. If someone's in here with that name, no offense. It's just I always use patient in room 201 and Nurse George and Nurse Lisa. Nurse George, this is what Lisa says. She says, George, just do whatever you want to do. That it's all right with me. Is that assertive, or what is that?
That's dismissive and a little aggressive.
Okay. But what if Nurse Lisa says, well, George, I hear what you're saying. I think we need to have a little bit more time to discuss, your ideas, and I can also, discuss my ideas, and we can come up with a solution. What is that?
Assertive.
Okay. Yes. So we're hearing what he's saying, validating that, he has some ideas, and as well as I do, and Lisa and George do. And then we're saying, okay, well, let's discuss them further, because sometimes you do have to discuss things further, but we're not just dismissing what he's saying is probably incorrect or needs some correction to it. We don't want to just leave him out there hanging. So yeah, that's an example. Let's see. So what if people on the healthcare team, you are the well, it doesn't matter if you're the nurse lead or not, but they're saying that you're not a team player because you don't want to follow the policies and procedures, because you do want to follow the policies and procedures. Let me go that way. If someone makes that statement to you, you're not a team player. You could have just taken care of, you just went on in there and answered my call. Like, is that assertive, aggressive? Is that nice?
That's aggressive.
It is aggressive, yeah. They're just, kind of, trying to make you feel, some type of way about it, but by saying you're not a team player. But it's a different way they could say that. That person could say, hey, I'm in this room. If one of my lights come on, would you at least answer it and see what they want and just let them know that I'll be with them, especially if it's not an emergency. So that's a different way of saying that. Okay. All right. So again, assertive is being, if you get scenarios, is it respectful? It can be direct, but like you said, you're not saying it aggressive. And that helps ensure that patients are safe and that we maintain that care coordination and collaboration. Those are things you need to think about when we're talking about if the communication is assertive or not. Is the patient safe? Are we being respectful? Are we ensuring that collaboration still happens and that care coordination? Those are how we can pick out. Is any other terms, those are terms that I'm using, any other way that you can identify? You please come off mute and share how you understand or remember or can pick out if we were to give you some statements that statement is assertive versus aggressive. Let me hear from you. Share with the group.
I think I had seen on something. I don't know if it was a lesson assessment, but it was like assertive statements. I don't know if it was like it'll start with I or okay.
That's correct. Assertive communication often involves using I statements to express our own thoughts, feelings, and needs clearly. This approach, they says, allows for honest expression without blaming or attacking others. So when you say I, it's like, the person's guard automatically is taken down because it's not like you're attacking them or blaming them for anything. And that in itself promotes that therapeutic communication. So you're spot on. Assertive communication often involves those I statements. That is correct. Any other things that you remember, or how do you quickly identify the difference between that passive versus just assertiveness? Because passive, you kind of yeah, whatever that decision is, or the things that you're saying, kind of leaves it out there just hanging. There's not any clear communication. There's really you're kind of not saying, so you're not being honest because you're not outright saying what needs to be said. Any
I
other
think
tips?
it lack accountability. That's another way to differentiate it. Because if you're not holding yourself or others accountable, then it could be considered a passive statement.
Okay. Okay, good. So now let's talk about, we talked about nonverbal and verbal. We've said some verbal things. So what are some nonverbal gestures that would indicate assertive communication? What are some nonverbal gestures that would indicate assertive communication? And I made some gestures, and I don't think those are assertive, but it's like the opposite of what I did. Let's give you some hints. Nonverbal that matches assertive.
I would say eye contact.
Eye contact, not that glaring in with those, glaring eyes, not that, but making that eye contact. You'll look away, but make that eye contact. What about your posture?
You have to have a relaxed posture. Like, don't come off as you're aggressive or standoffish. Avoid crossing your arms in front of people because that makes you feel like you're not welcoming or inviting into the conversation.
Got it. Standing with shoulders back in that confident posture. You don't have your arms folded. The patient's talking to you. You're looking away. What about the voice tone? Tell me about the tone of the voice of a person that's assertive. Are they yelling? Is it normal tone? Is it clear?
You would use a normal tone, but you also want to be direct in what you're saying. You don't want to be wishy-washy or sound like you don't know what you're talking about in a way.
Exactly. So laughing, like I said, not making eye contact at all, looking away, speaking loud, because then that, may indicate that you are being aggressive. And even a person that's hard of hearing, speaking louder actually distorts what you're saying. So you do want to speak in a clear, steady voice. Okay, so think about those nonverbal and verbal cues. Okay, did pretty good. Any questions about that? We're reviewing our last week's content. Any questions about that? I think we're doing pretty good with that. Let's see. Let's talk about conflict resolution. We can't get around conflict. That's just part of life. But we can, identify, try to identify what the conflict is. A lot of times what seems to be, or what people are saying initially, is really not what the conflict is. It could not be. And conflict is not always a bad thing. It's an opportunity for growth and learning, especially if something needs to be changed. It's an opportunity to revise those policies and procedures. But nevertheless, we can't avoid conflict. So we try to gather as much information so that we can, identify really what the issue actually is. So that goes back to that, making sure we have that clear communication. That clear communication, that we are establishing those therapeutic relationships early on. And so when there is something going on or conflict with your client or your patient, they'll tell you about the good, bad, and the ugly. So they'll come forward with it. They'll be encouraged to talk to you and let you know. So that first step, what's the first step in addressing conflict? Gathering that information. So whomever that the conflict is between, we want to encourage that communication so that we can get whatever all the points of, I don't want to say the facts, because sometimes it's not the facts, but it's whatever their side of it is. We want to encourage that communication. We want to get it from everybody, who's ever has a potentially to be involved. We want to ask for communication from there. It could be in writing, it could be a face-to-face interview, or whatever it is, but nevertheless, we need to gather all of that information. And how do we get it? By communicating with all the parties that are involved. So, like I said, that again, this conflict is an opportunity for growth and learning. Any questions about the conflict? So I know a lot of times most facilities have that those ethical, they call them something else now. QA committees, they have like different terms for them, but those are the committees that kind of like handles or try to help resolve or seek solutions for if conflict arises. But just know that it's a part of it, and it's an opportunity for growth and for growth. Okay, so we've been talking about leadership, and we're gonna go back to our slides here. So is there any time where we can bypass the chain of command? I know I went over in an exam review. Is there any time where the chain of command, this chain of command is important. It is important, that structure. It is there so that things are not overlooked. It keeps things structured and, just nicely structured. But is there a time where the chain of command can not be followed? I guess that's the question I'm trying to ask. Is there a time where the chain of command should not be followed? I heard somebody coming off mute. What did you say?
I was just going to clarify that state, like what you just said, like that it shouldn't be, you said where we shouldn't get them involved, like where we shouldn't go above that person.
Yeah, is there a time? The chain of command is there, and it is appropriate to follow the chain of command.
Mm-hmm.
It is important for that organizational structure. It is important so that that patient care continues. We talked about that care coordination. That chain of command is important. Is there a time when that we might have to not follow the chain of command? Is there any situation that you can think of where we might have to bypass a person that's on that chain? Is there any situation, and I'm trying not to say what I'm trying not to say. Is there any time, or should we always follow the chain of command? Let me ask it like that.
You can't always follow the chain of command if the person above you is the one causing the issue. You have to go above them.
Okay, so when we talk about conflict, what about just with patient care? Is there any time? What you say?
Emergency.
Got it. Yes. So yes. So 2 points. If that's person that's involved in the conflict, we will have to talk to them to help resolve the conflict. Because remember, we just said we want to get information from all parties involved. But when we talk about patient care in emergency situations, we're going to need an immediate action. more than likely, immediate action is going to be necessary. So we might have to bypass that usual chain. We might have to, it just depends on what that situation is. Okay. So healthcare professionals, we have a duty to report critical issues directly to those who can address them properly and promptly. The key word is emergency situation. So we need to go back over that? Did that clear it up? Was what I was trying not to say. And I'm trying to give you some scenarios and things. And, these are just things that's coming to my head about the concepts. Just trying to, do I need to go back over that, Miss Latricia?
I understand it now.
Okay.
I get
Okay.
it.
All right. Good. Okay. Now, did somebody tell me that Google was in here? I was reading the messages in the chat, but anywho, that didn't have anything to do with our concept here. So, chain of command. Is there ever a time that we would bypass the chain of command? And I go back to that conflict, even if that person's the conflict, at some point we're gonna have to get them to talk and to give their side or their information. But for sure in emergency situations. Because if we need an immediate response, we may have to bypass, that chain so that that patient, especially if it's life, limb, and eyesight, there's like emergency situations. Okay. Following the chain of command, it does start with addressing the concern directly and professionally. And then, like she said, you have to bring in someone else to mediate, to facilitate those conversations, because you do want to get everyone's side. And so you will have to bring someone else in if the conflict is with that person that's, on that next prong of that chain. Okay. I think, so what do we say the purpose of the chain of command is? Like, why do facilities have that? What is the chain of command? Is that needed? What's the whole purpose of it?
Gives you direction.
That structure, yes, that direction. And it keeps things aligned, structure aligned. There's some other words like that we can use. But yeah, that's what it is. Okay, so let's go back to our slide and I'll do some more what ifs and some more discussions here. Okay, so this kind of lines up with the slide that we're on anyways. Using problem solving steps. What is it? We're collecting that data. Share the screen here. Current slide. Collecting that data. That helps facilitate that communication. And sometimes when you're collecting data, you may have to pull phone logs, you may have to pull timesheets, you might have to pull various pieces of data in order to get to make sure that there's no gaps, to get a clear picture so that we can define what that problem really is. So you might have to gather the MARs, you might have to gather, whatever your checkoff list, whatever that is to correctly define what the problem is. And then from that, we set our goals, we decide on what's our next steps. What are those interventions? Then we implement them, and then did it work? Because sometimes, our interventions, they don't work, the goal may be partially met. Do we need to refine? We do, or do we need to give it a little bit more time? But hopefully we can solve whatever the conflict is. So occupational clinical skills, they are necessary, as well as organizational skills. You got to figure out, what you got to do for all your patients and get it done within your time frame, because, with medications, how much time do you have to give your medications? Or is there a certain time frame?
Hour before, an hour after.
Exactly. Now, what I'm seeing with most electronic records now, even that electronic MAR, they'll turn different colors. Like if it's, I've seen pink and red, if it's like overdue and that medication has not been documented. So it's not documented. It didn't happen. That means that medication hasn't been given. But I've been seeing pink and red in on certain electronic medical records. And then if it's within that time frame, I think it's for first it's white. I've seen white, and then it turns yellow. And then I've even seen green. I forget what green means. Have you all been using the electronic medical records or seeing those when you are in your facilities doing your clinical?
Green means it's been given.
Been given. Okay. So yeah, so they in that they put those, and who would have thought having something a certain color would help us manage our time. So it's like, okay, well, I got all green, so I'm good. Or, oh, I got reds. I haven't been doing so good. I'm actually out of my time frame. So, that's a problem. So whoever thought turning things different colors, but we have to get organized. So that's why if you have malfunctioning equipment, if the team wasn't distributed, fairly or as fair as it could be, we need to have conversation because it'll lead to conflict because you can't, you feel like you can't take care of your patients. So that's a discussion that we need to have. So, yeah. So those human relationship skills, the ability to get along with others and relate to people, but we're not changing. We're not breaking any rules now. So a person, they may get angry with you. They want you to sign off on something that you didn't actually witness. Don't you sign off on that. And don't share your passwords. Oh, I'll just document that. Nope, nope, nope. And so, we do want to be open and honest, but we don't want to do anything that's, that's going to endanger us and that's not the correct thing to do. We do want to have that non-judgmental attitude, just providing that best care for our patients. If that person comes in every 10th of the month, because more than likely, a lot of times when you see patients, especially if you're in the ER and they come back pretty, certain time frames, like almost like clockwork. Maybe they've run out of supplies. They've used up all of their medications. Maybe they can't get any more medicines or supplies for whatever reason. They're still a patient. We still provide that best care for that client. That client is getting a test done. And I mean, we may know what their cholesterol level is, or we may see what their BMI is, but we still have that non-judgmental attitude. We don't be like, oh, okay, I know why you're getting this test done. You must eat a lot of strawberries. No, we provide that best care for that client with that non-judgmental attitude. If we're like those home health nurses and going to the patient's home and they haven't folded their clothes up for the day, they have dishes in the sink. As long as we're safe and they're safe, we just go on in and provide the best care for the clients. Okay. Assignment versus delegation. We talked about delegation early on. So look at this assignment. We're distributing the work that each staff member is responsible for doing the given work period. So we just distributing it all out. So we have, all of this to do. We get this person some, we get this person some, we get this person some, but it's equal. When we are delegating, it's a transfer of responsibility. So, we're giving that person this task to do or these tasks to do. It's not distributed evenly. So in assignments, activities are consistent with job position and description, legal scope of practice, and educational background. The staff members assume responsibility and is accountable for completing the task. Anytime where you're delegating, we're transferring that responsibility to that person. They should agree to it. They must agree to it. And if they if they refuse, we want to have a conversation as why, what's going on. You never know. It could be that, maybe some history. It might be that that's a task. Even though they got checked off on it, they might not really know how to do it. So you do want to ask that, have that conversation. What's going on is the reason why you're refusing this task to be delegated. So where can I find information on delegation? The State Nurse Practice Act. Delegation is not a required act. State Board of Nursing may offer guidance. It will provide guidance for legal delegation and its regulations. Not every state allows an LPN to delegate. So again, if you're gonna get that information once you pass your NCLEX, the Board of Nursing, they're gonna send you all these welcome packages, and part of it is your Nurse State Practice Act. They make sure that you have it when you can log in, you can see it. And so just make sure that you become familiar with it, because that's what they're gonna that says that we can lawfully do. So that's what that's gonna be that baseline of that gauge, the thing that they're gonna gauge to see if what we did was the correct thing to do. Okay. Other resources and positions on delegation, the National League of Nursing, they're like at the top. And all the little other the different state nurses associations falls up under them. Usually when you subscribe or be a member of your state nurses association, for the most part, they have like a option where you can become a member of your National League of Nursing as well, because that's who your state bounces off of. So they kind of go hand in hand. So it provides those things that we can lawfully do, those rules, those regulations, those guidelines are interpreted for us. Okay, let's see were we correct when we identified those delegation rights early on. I believe we were. So right task. I know it says right task, but I like to say correct task, the correct circumstances. So the correct task, is this something that this person can lawfully do? Can they complete this task that we're asking them to do? Right circumstance. Is this patient stable? Unstable? What we're asking them to do, is it going to require judgment? Is it going to require nursing judgment? So we can ask them to, do, most facilities allow, especially hospitals allow unlicensed personnel to do the glucose 6. But when it comes to looking at taking that number and looking at the order to see if they require insulin or not, then that's nursing judgment. So they can complete the task, get the results, but that's as far as it goes. So the correct person, is this person qualified and competent? Because if that person refuses, remember, if they refuse the delegation, they want to have a conversation as to why. Because most of the time it's just that they know that, hey, I don't think I can complete that task safely. And you want them to tell you that. You don't want them to say, hey, yeah, I'll do that, and then go down there and cause harm to the patient. So most of the time, they don't feel like they're competent enough to do it, especially if it's something they haven't done in a long time. So, but like I said, you want that open, clear communication. And we want to communicate the correct directions and instructions. Make sure that the explanation is clear about the task, the outcomes, when should they report back. You want to be clear about all of those things. And then the right supervision. Even though we delegated, we said it early on, it does not alleviate or remove our responsibility from ensuring that task has been completed. So what I've heard, the head sees is big on delegation, y'all. They take all these scenarios. So just make sure we understand that part. Employee and nurse leader responsibilities. I think you all pretty much have a good understanding of that. So then, let's see what this one is saying. The licensed nurse responsibility determine what the patient needs are. Remember, that's coming from that care plan. That's that to-do list. That's that recipe. That's that map that guides us how to take care to provide this best care for the patient. Okay. Two-way communication, the receiver, the sender. Remember, use assertive communication, being clear and honest, use those I statements. Okay. Why is delegating important? It increases your effectiveness and the efficiency of the charge nurse. So it gives them time to do all these other things that cannot be delegated. And also, if you're that charge nurse, remember, it's not just you that you're having to see about, but you're overseeing the others too on the team. So it does, I don't want to say free you up, but it allows time for you to be effective in your management, your charging. Okay. May help nursing assistants increase and improve their job skills, because it'll be a task, like I just mentioned about, the person may be refusing the task because they may not feel like they're competent because it's a skill that they haven't completed in a long time. And so that will help that person to, stay abreast on their job skills, because they're actually being given the opportunity to perform those skills that they can't do. In certain settings like ICU, the nurse, for the most part, the ICUs that I've been in, you do everything. You feed the person if they need feed, you bathe them, you do all of that stuff. But in those settings that they can, do the finger sticks and things. You want to give them the opportunity to do that. It helps them improve their skill set. Just like those skills that you practice in the skills lab and you were able actually to do them when you went to clinical, that improved and strengthened your confidence and in your skill set in having an opportunity to do those skills outside of simulation. Because it's a little bit different when you're actually doing, with a real person. So before you delegate, the client must be assessed on their conditions, stable versus unstable. Remember, the CNA, the unlicensed personnel, they cannot delegate. Once that task has been accepted, that CNA or that unlicensed personnel cannot say, "Hey, I told Nurse Lisa I would do this, but here you do this." They cannot transfer the delegation. The delegatee can refuse the delegation. You do want to ask, what's going on? Okay, using the nursing process when assigning tasks or delegating. Going in assessing to see if that client is stable or not. Okay, so are there any questions? I'm going to stop and then I'm going to ask some more little questions here, give you some more little scenarios because we're about almost done with our content. Are there any questions? Let me find some more questions to ask. Let's see here. So if we are advocating for our clients, what does that mean? We're our clients' advocates. The nurse is the advocate for the client. Tell me, what does that mean?
That we will do anything that's ethical and morally correct for our client. Um, like we will take into consideration the cultural beliefs in their care. We will allow them to take a part of their care as well. And then we're that liaison in between them and the provider.
What if the doctor has ordered something and, like you said, you consider the patient, is a patient care partnership. We consider their beliefs, their culture, their values, their goals, things that are important to them. Do we just follow that order and tell the patient, "Hey, we have to do this. I have an order to do it"?
No, because you're basically supporting the patient's rights, needs, well-being, like everything that really aids in patient care. So that would include questioning something that could be contraindicated for the patient.
Okay. So you are hearing what she said. We would question that order. We would let the doctor know, well, hey, this patient is refusing it. Because remember, they have the right to refuse. So just because we have an order, if that is something that client is not wanting, then we advocate for that patient. We speak up for that patient, and in order to meet, their needs, their desires, their beliefs, they're not wanting this intervention, but we have a doctor order for it. But we will let the doctor know, hey, they're refusing this. Okay, good. Let's see here. So what about if we're working with others on the healthcare team? Should we, even though that person has physical therapy, they may have respiratory therapy, does that mean that we shouldn't be the advocate for that client?
You have to have communication.
Exactly. Remember we talked about that care coordination. We still want to collaborate with them. We can discuss that patient's condition. Remember that slide? It showed that nurse in the middle. We're still that patient advocate, even though all of those others are on the healthcare team. And so if there's an issue, they're going to come to you. We have to discuss it. We're going to be the ones that's pretty much spearheading it and leading the conversation. So we work collaboratively with the healthcare team because we want to make sure that care continues. Remember, it's the patient that's receiving the care. And so we want to provide that patient-centered care. So no matter if we are dealing with others on the healthcare team, we still are that client's advocate. Good. This time I think I'm gonna put the Nurse George and Nurse Lisa. Let's go back to them. Let's see. Nurse George tells Lisa, I'm working. I have to complete this task or put this Foley catheter in the patient that's in room 201. Just as soon as I finish, I will come and see if you need any assistance. Is that passive aggressive? I mean, passive assertive? Is it passive, assertive, or aggressive?
Passive assertive, I think.
So what is passive? Give me a
Um,
definition of it.
Not really being straightforward all
Okay.
the way.
Not being straightforward all the way. So let me
Or
go back.
letting things go to avoid conflict.
Okay. So let's go. That's correct. Let's go back to that's our definition. Let's go back to the situation, the scenario. Nurse Joyce tells Nurse Lisa, let me finish. Let me put this Foley catheter in the patient in room 201. Once I finish, I'll come and check and see if you still need any help. Is that passive, aggressive, or assertive?
Assertive.
Assertive.
Again,
I'm still say passive for that one.
you still saying it's passive? So define what's assertive.
Um, honest, honesty and straightforward, not without being, rude or
Okay.
aggressive.
Good. That is the definition of assertive. Nurse Joyce tells Nurse Lisa, let me go put this Foley catheter in patient 201. When I finish that, and I'll come and check and see if you still need my help.
Okay, I mean now I can see it as being more assertive, but I was thinking like I
What
guess because
part
he
did you
wouldn't
think was passive? What part did you think was passive?
by saying I'll come to you after to see if you still need help after I put the Foley in. But now I guess he did tell her when, so I guess that's what makes it assertive right there.
Okay. And then remember, negligence. Remember those patients that you're assigned to, you have a duty. You don't want to breach your duty by not performing or doing carrying out tasks as we should. So he's
Mm.
having to take care of his patient that's in room 201. He didn't say that he wasn't going to come assist, but right now I have this to do and I'll come and help you. So good. So that was a whole test taking scenario what we just did. And remember, next gen, you're going to have situations. Go back to what you know those definitions are and see if they match the situation. That was good. That was good. We did really good. So nurse care managers, remember, they develop and revise those clinical pathways, those care plans, and they coordinate the care across the different departments. So the PN, remember, we can reinforce the education, no matter if it's about whatever the education is, we can reinforce it. We gather information. We do our assessments. We may not do that focus assessment or that detailed assessment, but we gather that information, the subjective and objective information. We participate in care plans. And also we, of course, we collaborate and report back to that registered nurse, whatever our findings are. Okay, let's go back to our PowerPoint here. Any questions? Okay, let's see. I'm almost done with this PowerPoint in you. So then we're going to give you all the time after we go on our next break, to I'm gonna flip my slides here, you all. Let's go back. Okay. Now, are there any questions about the scenarios that I gave? I'm coming off the top of my head with stuff. I'm saying something incorrect. Let's make sure that we're saying the correct thing. Anybody disagree with that? Our findings, our final answer on that little scenario, please let us know. If we need to talk you back through it, we need to go back through it. Just let me know. Okay. Okay. So examples of duties not to delegate. What does your Nurse Practice Act allow? So just think about those things that the Nurse Practice Act say that you can lawfully do. Well, if you can lawfully do them, you've had to go to school, you have to take your NCLEX and pass that to get your license. An unlicensed personnel is they can't complete that same task. So an example of that would be, sterile procedures. If that client is unstable, that initial education. We reinforce. Although nursing assistants can collect simple data, they have not been trained to make decisions about or interpret, which we just said that an example that we gave was the glucose. Even the blood pressure, they can get the blood pressure, but we don't need, we wouldn't allow the nursing assistants to look at the order and say, okay, well, it says the blood pressure, if it's this amount, then we can give this medication. But they can get those measurements for us and report back to us what they are. The LPN job description goes back to that Nurse Practice Act and those policies, procedures. They'll give you your to-do list once you sign on, and they will give you your responsibilities to know your conditions of your residents at all times. At a minimum, we're making those every 2-hour rounds, but that doesn't mean that we just go in our patient's room or just see them every 2 hours. That's at a minimum, because it's our responsibility to know what's going on with those patients at all times, you all. Assign tasks to the nursing assistants. That's that delegation. We can delegate what's in there, what they can actually do, what's in their scope. Assist with certain procedures. We can assist physician with certain procedures. A lot of times, say, for example, if they're injecting knees or arms or joints or anything, certain procedures, they may ask us to, to set up that sterile field. That's something that we can do if they're getting ready to do some type of procedure where they have to have that sterile field set up. We do want to make sure that we're documenting everything, even though they may ask you to give a verbal explanation of what happened. They're going back to what you actually documented. They're going to look in that nurse's note. They're going to look on that medication administration record. Was this medication clicked on and said that you administered? That documentation. So make sure that you take the time to go back and document those things. What do I need to be in charge? What do I need to know to be in charge? The facilities, organizations, the skills checklist of other staff. What's on their checklist? Those are their to-do lists. What are those job descriptions of the team members? Because that's how you can tell whether or not is this a task that you need to be delegating or not. And then, of course, all the regulations. The National Patient Safety Goals, they have some for skilled nursing facilities. They have some for acute care facilities. Some of them are kind of the same, but there's a little difference. So these are all the information that you need to know so that you can make sure that you're charging correctly and within your scope of practice, so that you're not omitting anything. So there's it's a huge role, but you can do it. But the thing is making sure that you know all the things that you need to know. You may have to sign up on timesheets, verify time. It just depends on what facility that you're actually in. You may have to go in and do spot checks on medication counts, count certain meds. It just goes back to what that facility's policies and procedures are. Okay. Just some more tasks. What equipment? I was telling you all about the oxygen cylinders. Back in the day, we have to take them outside and do all this stuff to refill them. Now they have like these little machines that's right there. You just click the button and it just fills it back up. So, but knowing your equipment, how does it work? In the event, a lot of those specialty beds, they have a whole bunch of bells and whistles on them. But knowing that equipment, because if we don't use it appropriately, we tear the equipment up. So it is really important. So let's stop and take a 5-minute break. We'll see you in 5. And just a reminder, this recording is still going. Give me just a minute or so. I'm putting you in your groups here. Give me just a Okay, I'm going to open up the breakout rooms. I think I have everyone in the correct room. So check at a minimum, you all, this is at a minimum, we're checking in here, but you should be checking in after, before and after here. So just give me an opportunity to check in and I'll rotate to the rooms. So accept the invitation and go on over. Do your check-in, you may have to revise. DeAndre, are you there? Miss Thomas. Physical therapists and occupational therapists, they focus on mobility and activities of daily living. Respiratory therapist addresses breathing issues. Remember, the speech language pathologists, um, they specialize in diagnosis and treating speech and swallowing disorders. So they'll do those tests to determine whether or not this patient is actually aspirating. And also they can determine whether or not that patient needs thicker liquids. I don't know if you all have seen them or not, but some patients like water or juice, they'll have them thickened to honey consistency or nectar consistency. But again, we have all these different persons in different areas that's on the healthcare team. Physical and occupational therapists, they focus on that mobility and those activities of daily living, getting that person back up, moving back, driving, walking upstairs, bathing themselves, folding clothes. The respiratory therapists, they focus on those breathing issues, all things respiratory, lungs, COPD, different conditions like that. So just think about what kind of patients what has happened to a patient they might need to see whether or not they have a speech problem or swallowing problem. What might have happened to a patient? So the speech language pathologist specializes in diagnosis and treating speech and swallowing disorders because that liquids, the different consistency of liquids, if a person can't drink thin liquids, for example, just water, at that thin consistency, that water may actually go inside of that patient's lungs. So, but once they do those different swallowing tests and they determine whether or not, hey, this patient they can still eat and drink. This food might need to be pureed, in a different consistency so that they don't choke. So that food might be the consistency of honey. Can't get away from that effective collaboration. Remember, we have all the different people on the healthcare team, but it's going to be our providing that best care is going to go back to us collaborating, that active listening, and then sharing that relevant patient information. That S bar, just think, even when you're communicating with not nurse to nurse, but you're talking nurse to the respiratory therapist, the nurse to the healthcare provider. What is that relevant information? What information do they need to know about that client so that that client can receive that best safe care? We're on that team, so we do want to encourage, get input from them, from others on the healthcare team, because we're trying to problem solve. We want them to participate. Most of the time, they'll bring them in when they have those meetings, those care plan meetings. They'll bring the different healthcare team members in to get their input, to share the information that they know and that they understand, and get what recommendations they have. They do ask family members to come in and be a part of those meetings as well. And so, as the LPN, a lot of times we coordinate when those teams actually meet. They call them care plan conferences or care conferences. Depends on what facility you're in, is what they'll actually call them. But nevertheless, we're getting together, we're collaborating, we're communicating with the others on the healthcare team to see what's best for this client. So again, make sure that you look at the different, we're going to look back at those slides again about the tasks that the nurse can complete. The nurse can't complete a bed bath, but we know an unlicensed personnel can do that as well. Would an unlicensed personnel administer medication or perform Foley catheter insertion or wound care? No, they would not do those things. But the unlicensed personnel can assist with that bed bath. They can assist the patients to and from the restrooms. If that client is in distress or unstable, we're not going to ask that unlicensed personnel to assist with that client's care because they are unstable. But we can delegate measuring and recording vital signs if the client is stable. That's within that scope of practice of that nursing assistant. But remember, we're not asking them to interpret what those vital signs mean or what that blood glucose level actually means. We want to delegate tasks that are within the scope of practice for that person that we're delegating that task for. We want to avoid delegation where there is, where it's not within their scope of practice. That's just unlawful. We don't want to do that. We talked about the difference with assigning and delegation. Delegation involves transferring that authority to perform that selected nursing duty to that specific patient. To that specific person. We're transferring that task. When we are assigning, that's just distributing the task, because that's within the routine job responsibilities of that staff member. That's something that they will routinely do anyways. So we're just assigning those tasks rather than delegating the task. We talked about the autocratic leadership style. Autocratic leaders make decisions alone and they expect everyone to just comply. The democratic leaders, they involve the staff in making those decision makings. We get that input. Laissez-faire, there's really no direction. It's just like whatever people want to do, this is whatever they decide to do. It's okay. That's laissez-faire. Transformational leaders, they motivate and develop staff by sharing visions and fostering growth. They actually seek out opportunities and say, hey, have you thought about getting this certification? Have you thought about, applying to be the charge nurse? That's that transformational leader. Transactional leaders focus on clear exchanges, rewards for performance, penalties for failures. With the complexities, with the advances in technology, with healthcare, treatment options, they are rapidly changing. There's this continuous learning. We're life learners. We have to continuously learn to ensure that we're providing that quality of care for our patients. We have to be adaptable and just continue. We're life learners. We just can't get around that. And we want things to advance and get better so that people can, if they have a disease process, they can manage it and live life to the fullest. We want to empower our staff to participate in improving patient care and creating those work environments that foster professional practice and those key principles of effective nursing leadership. So in about 45 seconds, everyone should be back. In about 20 seconds, everyone should be back. So you all were having some robust conversations. You were identifying things you need to revise or do a little bit different. You were checking some things off your to-do list. And of course, I didn't record you all's conversations, but you all were talking it through as a team, was hearing people step in. You all were changing up roles as leaders, just listening to some of you all's conversations. Like, okay, well, this person was saying this, don't forget that. So that's really, really good. So are there any questions that we have? Make sure next week is week 6, you all, we have that exam. Make sure you commit to reviewing the classroom recordings, the exam reviews. Think about those test taking tips. Like we gave some scenarios tonight about knowing what the terms are, the concepts, and then applying them to a situation. Don't forget about those terms. Identify, answer what the question is asking you about that concept. So if a person is needing more to be retaught, more than likely they said something that was correct or incorrect. If reteaching needs to be done, did the patient state something that was correct or incorrect if they need to be retaught?
Incorrect.
Patient states something incorrect.
Got it. So that's how you talk yourself through the question. So if the question asks you what's a barrier to something, you're going to pick out what would be a barrier, something that helps or something that hinders.
Barrier is something that hinders.
Okay. So, don't forget all the entire answer choice has to be correct in order for you to select the answer, because sometimes it'll be just a little, I forget what they call them, fillers or something, but part of the answer choice will be correct, but the other half is not. Remember, the entire answer choice has to be correct. So if you don't have any questions, our time is up. Take care, and we'll see you next week. Remember, if you need it proctored, send an email. If you need to meet, send an email with some dates and times. Take care. Be safe. If anyone here needs to check in with me, we can start recording and we can talk. If not, I will see you next week. Marissa?